Morning everyone, how are you going? David here. Hope you're having a great weekend. For us it's a long weekend, and I hope you've got some fun things planned. Just a very quick video, some exciting publications just out this week, and this is the first one that I want to quickly talk about, and it's a very pertinent research finding that showed the effects of radiofrequency neurotomy in the lumbar spine. And I know a lot of my patients who present with low back pain have had this procedure done. It's often described to them as desensitizing the lumbar facet joints because they experience facetogenic back pain, or pain that's coming from arthritis associated with the lumbar facet joints. And they're told that if the medial branch nerve is burnt or stunned with a thermal needle, then the ability for the body to perceive pain from the inflamed facet joint is diminished. And that's absolutely true. Some people do get short-term relief of their back pain, but that's all it is. It's short-term relief. It's no different to a strong Panadol or a Nurofen, an anti-inflammatory. But the downside is that there are significant consequences of that, and the major downside is that for a long time we have been aware that when you burn the medial branch nerve, you also denervate the neural supply of the lower lumbar multifidus muscle. And the lower lumbar multifidus muscle is a critically important muscle that provides intersegmental stability to the lower lumbar motion segments. Okay, so in other words, it provides stability, the all-important joint stability to the lumbar spine. If you lose joint stability of your lumbar spine, you're in big trouble. You need to then do a lot of work and a lot of functional movement therapy in order to regain that stability. And if you can't regain that stability of the lumbar motion segment, you then need to move on from a functional stability rehab approach to a structural stability rehab approach. And that means surgery. Okay, so no one wants to have any spinal surgery, but if you lose intersegmental stability, you're staring surgery in the face. And so that's the background about radiofrequency. And let me just quickly show you the study. So between 2016 and 2021, about 51 sides were compared. 51 levels were compared, which is a 102 sides, left and right side of the spine. And what the researchers looked at were people who had unilateral, so the medial branch nerve, which is right there, okay, right there, the medial branch nerve right there was denervated using the thermal electrode. And this is the paraspinal musculature, erector spinae here, and multifidus muscle here. And when we see patients with back pain, they often have a lot of atrophy in that deep intersegmental multifidus muscle. And what the researchers found, scrolling back up, was that in the patients who only had unilateral procedures, of course, there was a significant difference between the cross-sectional area of the multifidus muscle. The average measurements were around 60.9 millimeters squared versus 19.6 millimeters squared on the treated side, and the untreated side still retained its muscle cross-sectional area or muscle bulk and function, versus the side that had received the thermal therapy or the radiofrequency ablation of the nerve, and assessing the patients preoperatively before the procedures. There was no significance between the cross-sectional areas before the procedure, and then within 2 years of having the procedure, okay, so a minimum of 2 years after the procedure, the assessment was performed, and that significant difference was noted with a p-value of 0.003. So that's a very significant finding, highly associated with the interventional procedure, and when it's highly associated, there's a strong likelihood of a causative association. So that's the really pertinent finding of this research. It's really undeniable that burning the medial branch nerve of the lumbar spine for pain is a really palliative procedure, and there's only a very small handful of people that you would consider that procedure for. Yet almost every single patient, young and old, that I see with low back pain symptoms, and there's thousands upon thousands of them, who visits a pain specialist, is kind of lured into this option of a purely symptom-based intervention, which is just band-aiding the problem, rather than actually saying, well, let's regain stability of the facet joint, eliminate the facet joint arthritis that's causing you pain, and we do that by delivering functional movement therapy, which then reverses the movement dysfunction, which then drives health back into the multifidus muscle, and then you regain your stability and your pain settles down. And what's the final conclusion here? Patients who underwent unilateral lumbar medial branch radiofrequency had a significantly higher long-term increase in fatty infiltration and a decrease in cross-sectional area of the multifidus muscle on the side of the radiofrequency neurotomy compared with the contralateral side, despite lack of significant pre-interventional degenerative asymmetry. That means pre-intervention everything was symmetrical and normal. Although direct causality cannot be concluded, long-term effects of lumbar medial branch radiofrequency neurotomy on paraspinal muscle health should not be ruled out. Larger studies with a prospective approach are needed to confirm our results and improve our understanding on the clinical implications of these findings. Okay, so that's big news, and I think the pain specialists really need to have a good think about what they're doing when they're offering medial branch radiofrequency neurotomy to patients with good old movement dysfunction related low back pain. And the very last important point, and I will talk to you a little bit about this in the future, movement dysfunction related low back pain and multifidus muscle atrophy has now been assigned, as of October this year, has been assigned a international classification of disease number. It is now established that movement dysfunction is a disease process, and that's a recent listing in ICD-10. Okay, so look out for that. You can now quite legitimately describe movement dysfunction as a disease process, as dictated by the International Classification for Diseases. So that's my news for today. Have a great weekend, and talk to you soon.